Human papillomavirus and cancers in the head and neck. The purpose of this presentation is to educate patients on background information, treatment, and intervention provided by speech-language pathologists regarding head and neck cancer that is caused by HPV. From this presentation, learners will be able to differentiate and compare treatment options regarding head and neck cancer, describe interventions provided by SLPs following changes from treatment of head and neck cancer. For human papillomavirus, or HPV, in cancers in the head and neck, literature demonstrates that at least 50% of cases of oropharyngeal squamous cell carcinoma, or OPSCC, is related to HPV. The prevalence of HPV-related head and neck cancers is estimated to be as high as 71% in population-based cancer registries. About 60 to 70% of cancers in the oropharynx may be related to HPV. Some characteristics of HPV-positive and HPV-negative head and neck cancers are shown on this slide for comparison. For HPV-positive, the younger ages are documented as the typical median age. Sexual behavior is typically associated with this head and neck cancer type, and the typical anatomic site is oropharynx, whereas the anatomic subsite is the palatine and lingual tonsils. The prognosis has been documented as consistently able to improve. As for HPV-negative, the older ages are documented as the typical median age. Sexual behavior is not typically associated with this head and neck cancer type. The typical anatomic site includes all sites, including the oropharynx. The anatomic subsites are also all the sites, which includes the tonsils. The prognosis has been documented as consistently worse compared to the prognosis of HPV positive. Some characteristics that have been associated with a favorable prognosis with HPV-positive related tumors are being a non-smoker, having minimal exposure to alcohol, holding an excellent performance status, as well as not having any comorbid conditions. Local treatment consists of radiation and surgery and are used to treat only the cancer. These do not affect the rest of the body. Systemic treatment consists of chemo and targeted therapy drugs, which go through the whole body. They can reach cancer cells anywhere in the body. It is common for cancer treatments to include 2 or more of these options. Adjuvant means after primary cancer treatment, and neoadjuvant means before the primary cancer treatment. Common treatment used with HPV-related oropharyngeal squamous cell carcinoma typically consists of surgery and adjuvant radiotherapy, with or without concurrent cisplatin or concurrent chemoradiation. Concurrent chemoradiation is used for the purpose of preserving speech and swallowing functions. Analysis suggests that there is a higher response rate to chemotherapy and radiation combined, and this has also been seen in an improved rate of survival for HPV-positive oropharynx cancer patients compared to HPV-negative. For surgical treatment, a common technique used is a minimally invasive surgery called transoral endoscopic surgery, or TES. There are 2 surgeries that are used within the treatment of head and neck cancer caused by HPV, which are transoral laser microsurgery and transoral robotic surgery. The first transoral endoscopic surgery technique is transoral laser microsurgery, or TLM. In this surgery, studies have shown that there is an excellent functional and oncologic outcome for early-stage pharyngeal cancer. As for disadvantages, studies have shown that there is a need for this specialized equipment and there is a steep learning curve. The other type of transoral endoscopic surgery is transoral robotic surgery, or TORS. In this surgery, studies have shown that there are strengths in the demonstration of safety, feasibility, as well as functional outcomes. Swallowing results were shown to be excellent following the surgery in one study. In regards to disadvantages, studies have shown that the cost, logistics of sharing, and need for specialized training and credential requirements are considered disadvantages with the TORS. Head and neck cancer can also be treated by concurrent chemoradiation. The following slides report 2 studies that focused on the treatment of head and neck cancer with concurrent chemoradiation. Although these studies did not focus on the treatment of head and neck cancer caused by HPV, it is still worth noting for concurrent chemoradiation information. In one study, patients were randomly chosen to receive radiotherapy and cisplatin, or just receive radiotherapy. The study was designed to detect a 15% increase in the rate of local and regional control. Results showed that the combination group showed local and regional tumor control, which suggests that this approach may decrease the risk of local and regional reoccurrence. However, there were adverse effects. The second study is similar to the first study in that it compares the combination treatment versus radiotherapy treatment in postoperative head and neck cancer patients. However, the study was larger than the first study. This study was designed to detect a 15% increase in the rate of disease-free survival. Results showed that in the 3-year disease-free survival, there were 41% of patients in the radiotherapy group and 59% in the combination trial. In regards to concurrent chemoradiation treatment, head and neck cancer patients may experience the following long-term side effects: dysphagia, xerostomia, feeding tube dependency from fibrosis and scarring of the pharyngeal muscles, chronic aspiration, and chronic fatigue. Patients may experience many changes from treatment in their head and neck cancer. Some of these changes may require assessment, diagnosis, or treatment from a speech-language pathologist. A speech-language pathologist may treat the following in head and neck cancer patients: voice changes, eating and/or swallowing difficulty, cognition changes, implementation of alaryngeal speech options such as electrolarynx and esophageal speech, implementation of augmentative and alternative communication.